Good evening, everybody, and welcome to tonight's APSA episode brought to you by the Cancer Committee. I'm Dr. Peter Ehrlich, and I am the current chair of the Cancer Committee. And with me tonight is my friend and colleague, Dr. David Rodenberg, who is the vice chair of the Cancer Committee. Tonight for our session, we are combining science and education. We identified 3 outstanding abstracts about pediatric solid tumors. And then the Cancer Committee went and did a deeper dive around those tumors. The Cancer Committee has pre-recorded questions for the presenters. And then at the end, we will all be able to come together and take your questions. Dr. Rodenberg, I turn it over to you.
All right. Thank you, Dr. Ehrlich. So the 3 abstracts that are being presented today, the first one is expression of programmed death ligand 1 in drug-resistant neuroblastoma, being presented by Dr. Nicholas Skirchich from Rush in Chicago. The second abstract is molecular genetic augment cytopathological characterization of pediatric thyroid nodules, being presented by Dr. Emily Christensen-Legay from Yale. And the last abstract is long-term outcomes for patients with anaplastic bilateral Wilms tumors on AREN 0534, being presented by Dr. Rodrigo Romeo from Dalhousie in Nova Scotia, and is part of the COG Wilms tumor committee results. Peter, back to you.
All right, let's start with our first presentation, and we'll see everybody at the end. Thank you.
Thank you for allowing me to present our work regarding the use of molecular genetics to augment the cytopathologic evaluation of pediatric thyroid nodules. Pediatric differentiated thyroid carcinomas arise from the thyroid follicular cell. And while pediatric DTC represents only about 1.8% of all thyroid malignancies, the majority of which are adult DTCs, according to the SEER database, incidence has increased 2.3-fold over the last 2 decades. And papillary thyroid cancer is the second most common cancer of adolescent girls. Diagnosis of DTC begins with the detection of a thyroid nodule, typically by palpation or visualization by the patient, a close family member or friend, or by a primary care provider. Detection of a nodule should be followed by an ultrasound of the thyroid. And the TI-RADS classification allows for synoptic reporting of a thyroid nodule coupled with a scoring scheme to help predict malignancy guide the subsequent referral to biopsy. In the illustrated nodule in the left lower corner of the screen, the nodule is solid, hypoechoic, but it is wider than it is tall. It has smooth margins, and there are no tail artifacts. This gives a total score of 4, which leaves it as a TI-RADS 4 or moderately suspicious nodule. Such nodules are usually referred to ultrasound-guided FNA, and the results of this histology is classified according to the Bethesda classification scheme. This classification scores cytologic smears from Bethesda 2 benign lesions to Bethesda 6 malignant lesions. Benign cytology is characterized by well-ordered follicular cells in a background of colloid matrix, whereas Bethesda 6 lesions are characterized by papillary fronds, intranuclear inclusions, and intranuclear grooves. In the middle, these indeterminate Bethesda 3 and 4 categories are far more cytologically heterogeneous, containing cells with architectural atypia, cell crowding, microfollicles, and scant colloid. Each category is associated with a risk of malignancy, and it is known that the risk of indeterminate lesions is higher in children than it is in adults. In benign lesions, we recommend clinical follow-up, and in malignant lesions, we recommend referral to a surgeon for total thyroidectomy. Bethesda 3 and 4 lesions, however, are referred typically for thyroidectomy, with then a recourse to completion thyroidectomy if malignancy is seen on the final pathology. This means that some patients who have benign nodules undergo unnecessary surgery, while others undergo redo neck dissection for the purpose of completion thyroidectomy. And this means that there is a opportunity for process improvement. It is known that the majority of molecular drivers of thyroid cancer are members of the MAP kinase cascade. And here I've drawn arrows on some frequently mutated key drivers. In adults, these mutations are reproducible enough to know that the knowledge of a given mutation could help predict the aggressiveness of disease. However, this is less well defined in children. Over the last decade, a number of commercially available platforms have been used to help identify mutation based upon cytologic smears. ThyroSeq is now in its third version and uses next generation sequencing and a 112 gene classifier to help predict, to identify mutations and predict malignancy. Another commonly used platform is in fact a combination of two platforms, ThyGenNext and Thyromere, which uses targeted NGS in 8 genes and then follows it by a 10 microRNA classifier to help predict malignancy. And these have very good performance metrics in adults, but have not been extensively validated in children. And we do know that pediatric and adult PTC harbor some genetic differences. Namely, there is a much higher prevalence of gene rearrangement in pediatric PTC and a lower prevalence of gene point mutations. At Yale for the last decade, we've been using molecular genetics in adults as part of the pathologic characterization of indeterminate thyroid nodules and have gradually increased the frequency with which we have done this in children. So we started out by looking at the patients who had thyroid nodules resected over the last 15 years. We identified 164 patients with a mean age of 16 years. 85 or just over half of these patients had some available molecular genetics. 84 of these 85 had BRAF testing. This is an in-house test. So 31 of these were BRAF positive. These patients went on for total thyroidectomy. At 33 were BRAF negative and had no further testing performed. Typically, these patients then underwent a thyroid lobectomy. But there were 20 BRAF negative lesions plus one additional one who had expanded genetic testing performed. And in these, we identified 12 or 50% of these had positive mutations. Of these, there were 7 fusions and 4 point mutations, 3 of which were NRAS, all benign follicular adenomas. When we look at a distribution of who had testing by Bethesda class, we see that about 70% of the patients were Bethesda 5 and 6 lesions. And these were basically BRAFs, which are round on final pathology specimens. But there about 25% of patients in indeterminate categories had genetic testing performed on cytology specimens. This is a distribution of the genetic mutation by Bethesda class. And if we look more and cone in more closely at the indeterminate categories, we can see that there were 21 Bethesda 3 patients, 14 who were tested for BRAF, and 5 who had expanded testing. And there were 19 Bethesda 4 patients, 9 of whom were tested for BRAF, and all 9 who then underwent expanded testing as well. If we had confined our recommendations for surgery based upon clinical presentation, ultrasound finding, and traditional cytopathology alone, we would have recommended 21 lobectomies in the Bethesda 3 lesions, 17 in the Bethesda 4, plus 2 total thyroidectomies in Bethesda 4 for multinodular goiter. However, when we expanded our classification by using molecular genetics, we were able to recommend an additional 6 total thyroidectomies, thus preventing 6 completion thyroidectomies in this patient population. One other important observation we drew from this is that cytologically typical classic PTC architecture is really enriched for these BRAF V600E mutations, whereas non-BRAF mutations really cluster in Bethesda 4 lesions. And although these are supposed to be follicular neoplasms, most of these turned out to be variants of papillary thyroid cancer. So in conclusion, molecular genetic testing of pediatric cytology specimens, particularly those in indeterminate categories, can augment surgical decision-making. BRAF mutations appear to correlate with classic papillary carcinoma on cytology, but gene fusions and other non-BRAF point mutations may be associated with cytology less typical of PTC. Further studies, of course, are needed to validate ours. It's really just the tip of the iceberg. Thank you very much, and here's my contact information.
All right, thank you, Dr. Christensen-Legay. That was a wonderful talk. We have 3 discussants here. I'm going to ask a few questions. I'm Shahab Abdesalam, and then we're going to have Dr. Brian Coakley discuss where thyroid operations stand in 2021. And then Dr. David Rothstein is going to finalize the discussants with a talk on what are the controversies between in who should be managing thyroid disease in the pediatric population. So, Dr. Christensen-Legay, a few questions for you. So traditionally, those with indeterminate pathology would ordinarily proceed to a lobectomy/thyroidectomy. So testing to rule in cancer would only change management in a small subset of patients based upon this technology. Do you see this technology as being more useful for ruling out cancer and continued observation, or for ruling in cancer to determine if total thyroidectomy should just be the first line of action versus lobectomy, then total thyroidectomy? And kind of along those same lines, so we know that in the adult population versus pediatric population, pediatric thyroid nodules have a 5 to 7 time increased risk of malignancy relative to adults. So is molecular testing as appropriate as it is in the adults to attempt to avoid an operation? Obviously, the closer we can get to 100% sensitivity and specificity, the better that will be. Do you see molecular testing approaching these values? And then the final question is, given that there's a relative risk of malignancy in all subsets of the Bethesda classification system, should molecular testing be done on all FNAs, or do you see its most important role being with the indeterminate pathology?
Thank you, Shahab, Brian, and David. For the first question, can molecular testing be used as a rule out as well as a rule in? For those familiar with molecular testing in adult differentiated thyroid cancer, commercially available panels widely promote this rule out feature. For instance, a Bethesda 3 lesion with no detectable mutation on molecular testing may drop from a 10 to 15% risk of malignancy to a 2 to 5% risk, and this reduction in risk is often enough for patients and providers alike to pursue expectant observation. However, the genetics of pediatric thyroid cancer does differ from adults in that there's an observed enrichment in oncogenic fusions and a comparatively higher percentage of thyroid cancer without any identifiable somatic alterations. Our study did not allow us to look at the molecular genetics as a rule-out tool. However, last year, using a combination of ThyGenext and Thyromere, which uses a classifier optimized to detect mutation-negative thyroid lesions, researchers at CHOP working on archive specimens and not FNA found a sensitivity of about 70% and a sensitivity of about 70% and a specificity of about 95% for identifying malignant thyroid nodules. As with our study, there were no false positive results suggesting that a positive microRNA classifier could be used to rule in malignancy and indeterminate thyroid nodules by cytopathology with a high positive predictive value, but about 30% of malignant lesions were missed. So I think that additional improvements need to be made in the test sensitivity before it could be used as a rule-out test. These classifiers were all initially developed using adult thyroid specimens, so classifier optimization may be possible to increase the sensitivity for pediatric thyroid nodules. A more philosophical question, however, is how sensitive the test needs to be before pediatric surgeons parents and our patients feel that observation in serial ultrasound is not only a reasonable, but possibly a recommended approach. That's a question that I think needs to be discussed in an open forum among providers and patients. And of course, it should be stressed that a decision not to operate is not equivalent to a decision not to follow, and that patients with known thyroid nodules need to be under the care of an experienced endocrinologist who can help ensure adequate surveillance. The second question, should all lesions be tested? I think this can be answered on several different levels. From a pure research perspective on gathering data on the biopsy nodules, yes, it would help to better define the landscape of molecular genetics within pediatric thyroid nodules. From a decision-making standpoint, in terms of operative strategy, for me, the molecular genetics really have relevance only for indeterminate lesions, those Bethesda 3 and 4 on FNA, or in the rare case of a locally advanced thyroid cancer, which might benefit from upfront targeted therapy rather than a primary attempted surgical resection. In my practice, I definitely feel comfortable following asymptomatic Bethesda 2 lesions, which are less than 3 to 4 centimeters in size with serial ultrasound, and I do recommend thyroidectomy for Bethesda 5, and 6 lesions. From a purely logistical standpoint, it is often easiest to obtain another pass for molecular genetics at the time of the FNA and before the results of the FNA are known, and then to send that pass for molecular testing if it comes back an indeterminate nodule. I would have to say that the insurance reimbursement and approval of this is a bit of a moving target, so that may have to be checked prior to ordering any molecular testing.
So with that, we'll move on to the next speaker, Dr. Coakley, who will now speak on where we stand with thyroid cancer in 2021.
Thank you, Shahab. So altogether, children account for less than 2% of all thyroid cancer cases. But the incidence of thyroid cancer in children has more than doubled over the last 4 decades. The majority of patients have papillary thyroid cancer, although a follicular variant of papillary cancer, follicular cancer, and medullary cancer types are also seen. The incidence of thyroid cancer increases substantially with increasing age, as we see an incidence of only 0.04 cases per million among patients 4 years old or younger, while patients 15 to 19 years of age experience an incidence of over 15 cases per million. While thyroid nodules are much less common in children than in adults, the pediatric nodules are more likely to harbor malignancy than their adult counterparts. And ultrasound and fine needle aspiration, or FNA, remain the mainstays of workup to guide future treatment. The 2015 American Thyroid Association guidelines offered some key differences in the care of pediatric thyroid disease versus that of adults. In contrast to adults, the totality of ultrasound findings, rather than nodule size alone, should determine the need for FNA, and all FNA should be performed under ultrasound guidance. Preoperative FNAs of hyperfunctioning nodules are not required as long as the lesion is removed. Children can develop a diffusely infiltrative form of papillary thyroid cancer, and this condition should thus be considered in a clinically suspicious gland. Resection, as opposed to repeat FNA, is favored for indeterminate nodules, while resection rather than radioactive iodine is favored for autonomous nodules. The 2015 ATA guidelines also offer a standardized approach for the risk assessment of thyroid nodules in children, which ultimately leads to surveillance, FNA, or surgery. In patients undergoing thyroidectomy, radioactive iodine is favored in the postoperative setting only for those with unresectable microscopic disease, pulmonary metastases, or extensive regional lymph node involvement. In patients with MEN2, the specifically mutated RET codon correlates with the aggressiveness of medullary thyroid cancer. Thus, multiple international groups have suggested using these RET codon mutations to determine the optimal timing of thyroidectomy. I will now turn it over to Dr. Rothstein, who will talk about the role for specialization in thyroid surgery.
Thanks, Brian. I'm going to finish out our commentary by making a few comments on health services, asking questions about who should be operated, where, by whom, and for what reasons. We might ask where pediatric thyroidectomies should be done. Should they be done at a children's hospital by any one of a combination of the below, a pediatric surgeon, a pediatric otolaryngologist, an experienced adult thyroid surgeon operating at a children's hospital with a children's team, or perhaps a combination of a pediatric surgeon and an adult thyroid surgeon? Or should children be operated at an adult hospital by an experienced team who operate on thyroid disease, perhaps daily? So to answer the question about where patients are undergoing thyroidectomy, I'll show you results of a 2016 paper by Al-Qureshi et al. That took a patient from a subset from the National Inpatient Survey from 2003 to 19 and stratified by surgeon volume. You can see that about half of patients were operated on by surgeons who did 3 to 30 thyroidectomies per year as that middle tertile. If you look at surgeon specialty, perhaps not surprisingly, a great majority of patients are actually operated by adult surgeons who are neither pediatric trained nor head and neck specialists or laryngology specialists. And if you look at the hospital volumes, this may be a little bit less informative because of the wide range, but a majority of patients are operated on at hospitals with a wide range, 11 to 198 cases per year, representing that middle tertile as well. This paper by Al-Qureshi looked at outcomes in terms of risk factors for complications, and they found a strong association of surgeon volume and outcomes, mirroring perhaps what we see in many adult papers. They did not find any association of outcomes that were specific to specialty, but it was really the volume. Now, in fairness, they weren't able to include data on extent of surgery, including lymph node dissection, or other patient factors that may affect the multivariable model. What should be versus what is, a recent specialization survey by Dr. Rich and al. Showed that 6% of our community identifies as having a niche in endocrine surgery. Interestingly, if you look at case exposure in general surgery, has actually risen in the last couple of decades. So graduating chief resident has been doing about 20 thyroidectomies in his or her residency. And similarly, there's been a slight increase in the mean thyroid operations performed by graduating pediatric surgery fellows. I would argue, of course, that these numbers don't represent a mastery of the procedure or of treating thyroid disease. We might agree philosophically that multidisciplinary care is best, although maybe it's hard to prove that. But certainly the 2015 ATA pediatric guidelines stress the importance of multidisciplinary care, and that's something I think we've tried to hew to. Volume, multiple adult studies show an inverse relationship between complications and surgeon volume. That number seems to be in multiple publications to be about 25 to 30 thyroidectomies per year. And it's hard to know if that's simply the learning curve or maintenance curve, or there's some arbitrary use of cutoffs and tertiles or other stratification. So what do we do with this information? Like politics, all thyroid surgery might be local. In my own experience, my previous job, I was doing the thyroid surgeries about 6 to 10 lobectomies or thyroidectomies per year. But given that low volume, I did all of my operations with an experienced adult thyroid surgeon who came over the bridge and operated with me, along with our fellow. In my current job, it's a bit of a different referral pattern. So most of our operations are done by the pediatric otolaryngology team. They have excellent outcomes, but none of those individual surgeons has that 25 to 30 per year thyroidectomy case volume. And who will drive these decisions? We talk about self-policing, but I wonder if it'll be hospital credentialing or insurance carriers that drive the discussion. These are obviously more questions than answers, but I think it's good to have these discussions and to think about how we provide care in our local settings.
I'd like to thank the APSA Program Committee and Cancer Committee for the opportunity to present our Wilms tumor work. I'm presenting today on behalf of my co-authors and the Renal Tumor Committee at COG. We have no disclosures. We all know that bilateral Wilms tumors are not very common. And when we're dealing with them, there's certain things that are very specific to this patient population. For example, patients with unilateral Wilms tumor that relapse usually do so early, after 1 to 2 years after the end of therapy. But there's some suggestion in the literature that bilateral patients can be more prone to late events. Furthermore, because patients with bilateral tumors are often treated with nephron-sparing surgery, there is a concern about the impact that microscopic positive margins can have on final oncological outcomes. Anaplastic Wilms tumors are also rare or less common compared to their favorable histology counterparts, and we know that they carry a worse prognosis. And anaplasia usually is classified into focal or diffuse anaplasia based on the appearance under the microscope. There's not a lot of information about patients with the combination of both anaplasia and bilateral Wilms tumor. So this is a publication from 2006 and based on National Wilms Tumor Study 5. And you can see there at the bottom that the outcomes were relatively poor for patients with diffuse anaplasia. But the treatment was very heterogeneous, and there were very few patients that were evaluable at the end of the study period. Our objective is to describe the long-term outcomes of patients with anaplastic bilateral Wilms tumors that were treated under the last bilateral protocol, AREN 0534. So we were really focused on long-term outcomes, and particularly 4 aspects. So we were interested in the pathology concordance or discordance. In other words, patients will have anaplasia on one side. Do they have anaplasia on the other side, or do they have anaplasia favorable histology? We were interested in late events, which were defined as relapse or death after 2 to 3 years after the end of therapy, to address this difference between bilateral and unilateral tumors. We were interested on the impact of the margins on the oncological outcomes. And finally, we sought to compare the outcomes of 0534 with its predecessor. So AREN 0534 was the first clinical trial focused on bilateral Wilms tumors. It was open for enrollment from 2009 to 2015. And in a nutshell, the treatment for patients enrolled in this trial consisted of preoperative chemotherapy without a biopsy, followed by surgery, usually at week 12. And the surgery should be an attempt, at least, at bilateral nephron-sparing surgery. And as you can see at the bottom of the slide, the primary outcomes of the trial are listed, and they have been reported in the reference provided. So our project is really a secondary data analysis of the patients enrolled on 0534. Our inclusion criteria were any patients that had evidence of anaplasia, either focal anaplasia or diffuse anaplasia, on central pathology review, and who also had at least 5 years of follow-up. And for those patients, we collected all the information that we mentioned before in the objectives. So we collected demographics, we collected oncological events such as relapse or death, and we collected their surgical margins. So on to our results. There were 189 patients enrolled on 0534. And as you can see here, about 13% had evidence of anaplasia. There were 17 cases of diffuse anaplasia and 8 cases of focal anaplasia. Most patients were females. There was a female preponderance. And as you can see on the slide, the median age of enrollment was close to 4 years, and the median follow-up for the survivors was over 6 years. In terms of the pathology, you can see that of the 17 patients with diffuse anaplasia, only 4 had evidence of bilateral anaplasia. So most patients had anaplasia on one side, favorable histology on the other side. And for focal anaplasia, it was even more rare. Only 1 patient out of the 8 had evidence of anaplastic disease on both kidneys. So focusing a little bit on the focal anaplasia group, you can see that 7 out of 8 were alive at the last follow-up, and only 1 died. And what's interesting is that the patient who died, he died of a relapse on the favorable histology side, so not on the anaplastic tumor side. And this relapse happened 5 years off from the end of therapy. There was only 1 other patient that relapsed in this group, and it was a stage 2 patient with focal anaplasia that relapsed, and at relapse had evidence of diffuse anaplasia. And this patient is alive at 8 years of follow-up currently. For patients with diffuse anaplasia, there were 17 of them, and as you can see here, 12 are alive and 5 died. Of the patients who are still alive, there were only 2 who relapsed. So there are 10 patients who are alive without an event. And of the patients who died, only 2 relapsed and 3 died of disease progression. The recurrences were 1 local and 1 metastatic to the lungs. And if you look at the box here, just with the details about the events, you can appreciate that of the 4 patients who relapsed, they all did within the first year after the end of therapy. So they were early events, not late events. In terms of positive margins, and here we're focused only on the diffuse anaplasia group, there were 9 out of 17 patients that had positive margins. And as you can see here, 5 of them, 5 of the 9, are alive without an event. 2 relapsed and are still alive, and 2 have died. It's important to mention that because these patients have anaplastic disease, they would have received radiation therapy per protocol, regardless of their margin status. So all of these patients received 20 grays of radiation to the kidney that contained anaplasia. These are our survival curves for the patients with anaplastic bilateral Wilms tumor. So you can see event-free survival, overall survival. And here are the estimates for the 7-year event-free and overall survival. If you focus on the 2-year mark and beyond and later, you can see that we did not appreciate a lot of late events in this patient population. So most of the events happened early, just like what we observed for the unilateral Wilms tumor, unilateral favorable histology Wilms tumor patient population. Finally, when we compared 0534 with National Wilms Tumor Study 5, clearly there have been improvements in the outcomes, and both event-free survival and overall survival are better, which is great news. So in conclusion, we found that discordant pathology is usually the norm for patients with anaplasia and bilateral Wilms. So usually patients will have anaplasia on one side, favorable histology on the other side. Late events are not common, and in fact, all the patients with diffuse anaplasia that relapsed did so within 1 year after the end of therapy. And the significance of a microscopic positive margin is still unclear, given that it seems like patients that receive radiation, that does not appear to negatively affect the outcome, but of course that needs to be carefully studied in the future. Once again, thank you very much for the opportunity to present, and I'd like to acknowledge my colleagues at the Renal Tumor Committee at COG, and I hope we can have a productive discussion about this topic. Thank you.
Thank you for your attention as Dr. Romeo presented long-term outcomes for patients with bilateral anaplastic Wilms tumor enrolled on COG AREN 0534. Doctors Brown, Balther, and myself from the APSA Cancer Committee are going to hold a deeper dive discussion on some of the relevant points from this abstract.
Over the last 50 years, survival for children with Wilms tumor has dramatically improved. It approaches 85% for all comers and close to 100% for children with low-stage tumors. However, children with bilateral Wilms tumors have not seen the same improvements. Synchronous bilateral Wilms tumor is rare, occurring in approximately 5 to 7% of patients with Wilms tumor. In the most recent study, prior to the current study, the National Wilms Tumor Study 5, outcomes for bilateral Wilms tumor were an overall survival of 61%, but this dropped to 44% for those with anaplastic histology. Previously, there had been no clinical trial of patients with bilateral Wilms tumor. Single institution and collaborative studies have informed management decisions for patients with bilateral Wilms tumor. From these single institution and collaborative studies, we know that children with bilateral Wilms tumor have poorer outcomes than those with unilateral tumors. This includes survival, renal failure, and toxicity from therapy. We also know that these children often receive prolonged preoperative chemotherapy that has multiple pitfalls. First, preoperative chemotherapy can produce histologic changes such as rhabdomyomatous and stromal differentiation, which we know do not respond to additional chemotherapy and are associated with a good prognosis. Second, anaplastic histology is common in children with bilateral Wilms tumor. Lastly, we know that we can expect a 50% reduction in tumor size by 4 weeks of therapy. Therefore, progressive or non-responsive disease mandates a surgical intervention to obtain tissues from both kidneys to define tumor histology, especially when looking for anaplasia. Despite the useful information gained by these studies, they are limited by variable treatment approaches and poor outcomes that may be related to the lack of a formal clinical trial for this subset of patients. Therefore, AREN0534 was designed with the following goals in mind: to improve event-free survival to 75% for patients with bilateral Wilms tumor, to prevent complete removal of at least one kidney in 50% of patients with bilateral Wilms tumor by using pre-nephrectomy 3-drug chemotherapy induction with vincristine, actinomycin, and doxorubicin, and to have 75% of children with bilateral Wilms tumor undergo definitive surgical treatment by 12 weeks. Which brings us to our first question. Dr. Romeo, what is the rate of tumor histology concordance among patients with bilateral Wilms tumor, and why is this important?
Thank you very much for your question, Dr. Brown. So what we found is that the rate of concordance is actually low, meaning most patients that have anaplasia have it on one kidney, but not the other one. So the other kidney will have favorable histology disease. So in our study, the discordance was 80%, which is in keeping with previous publications and the National Wilms Tumor Study Group. I think this is really interesting because in the era of new ways of getting tissue and liquid biopsy or getting DNA, free circulating DNA or urine DNA, we'll be able to know that patients have anaplasia, but we have to remember that they usually don't have anaplasia on both kidneys in the setting of bilateral Wilms tumor.
Thank you. I think this study confirms some really important findings that we have seen in prior studies, which is mostly that the rate of discordance is extremely high in the 80s on both studies. This stresses the importance of individually staging each kidney. And I think it's really fascinating. You mentioned the liquid biopsies. We know that biopsy is an important point when trying to identify anaplastic histology, and that in the National Wilms Tumor Study, core biopsy identified anaplasia 0% of the time. In fact, anaplasia was often not identified until definitive surgical resection. Second, from that study, we also saw that the average time interval to subsequent biopsy was 20 weeks, which is quite a long interval of chemotherapy prior to any intervention. Therefore, the recommendation is to proceed earlier with an open biopsy or resection when possible, after 6 to 12 weeks of initiation of chemotherapy in cases where there has been limited tumor response. The goal of this is to limit the duration of chemotherapy targeted to favorable histology Wilms tumor, especially in the presence of bilateral disease and anaplasia.
Thanks, Dr. Brown. We're going to transition to the second question. So that question is, what is the incidence, event-free survival, and overall survival for patients with diffuse and focal anaplasia in the setting of bilateral Wilms tumors? And how does that compare to the incidence, event-free survival, and overall survival for patients with anaplasia in a unilateral Wilms tumor?
Thank you very much, Dr. Walter. What we found is that the incidence of anaplasia on this last study was actually a bit lower than what had been described for National Wilms Tumor Study 5. So we found 13% of anaplasia in this group, and what had been described was around 20%, I believe, in the previous study. And the outcomes on 0534 were slightly better. We were happy to see that there was an improvement in both event-free and overall survival. Furthermore, I think it's important to stress that focal anaplasia is much better than diffuse anaplasia. And diffuse anaplasia is still probably our biggest challenge when treating patients with Wilms tumors because the outcomes are really not good. And it's an area that we need to improve in order to improve the survival for these patients.
Thank you, Dr. Romeo. To begin, I think it's important to understand the definition of anaplasia, as well as the difference between focal and diffuse anaplasia. So anaplasia is defined as nuclear and mitotic atypia on pathologic examination and is a marker for adverse prognosis. It is also a marker for increased resistance to therapy. Focal anaplasia is the presence of a few distinct and localized regions of anaplasia within a primary tumor that otherwise demonstrates no nuclear atypia. Diffuse anaplasia requires the presence of anaplastic cells outside the kidney, the presence of anaplasia in a random kidney biopsy, anaplasia in more than one region of the kidney, or anaplasia in one region with extreme nuclear pleomorphism in another site. In order to assess the incidence of anaplasia, we turned to a study from the SIOP experience published in the Pediatric Blood and Cancer in 1999. 5.5% of the 1,554 children in the study were found to have anaplasia. Of those, 86 patients with anaplasia, 81% had diffuse anaplasia, while 19% had focal anaplasia. The next question is, how does this compare to bilateral Wilms tumors? So the National Wilms Tumor Study data published in 2006 in JPS identified 189 children with bilateral Wilms tumors. The incidence of anaplasia was 14%, while 4 of those patients, or 2% of the overall, had bilateral anaplasia identified. In another study out of Italy published in 2013, which included 90 children with bilateral Wilms tumors, the incidence of anaplasia was 20%, as previously mentioned. These findings indicate that anaplasia is more common in bilateral Wilms tumors than in unilateral Wilms tumors, but these previous reports were higher than seen in this recent study. And finally, survival in the setting of anaplasia was also studied in the aforementioned studies. The 4-year disease-free survival in the bilateral Wilms tumor with diffuse anaplasia group was only 51%. The 4-year overall survival in the setting of focal anaplasia is 75%, while it is as low as 41% in the setting of diffuse anaplasia.
So we'll switch to the last 2 questions on the topic of the optimal management of margins in the setting of positive margins and potentially additional treatment. So Dr. Romeo, what is the optimal management of positive margins in this particular setting with either diffuse or focal anaplasia for patients with bilateral Wilms tumor?
Thank you for that question, Dr. Aldrink. Probably the most controversial question related to our paper. So it's important to highlight that all of these patients with anaplasia would have received radiation to the surgical bed per protocol. But out of the 9 patients that had positive margins, so with diffuse anaplasia, out of 17 patients, 9 had positive margins, and 5 of those 9 are alive without an event. So we really want to be very careful about drawing any significant conclusions from such a small number of patients, but it would seem that microscopic positive margin does not necessarily require any additional treatment other than the radiation that was already planned. But obviously that still needs to be studied further and probably refined moving forward.
Yeah, thank you. I agree. I think that margin status at the time of definitive surgery in this study did not seem to impact outcomes in the context of advanced multimodality therapy, which does include radiation therapy for anaplastic histology as well as positive margins. And so it's important to ensure that all of these patients are properly enrolled on cooperative group studies and receive appropriate therapy. The recurrence rates for favorable histology bilateral Wilms tumor were similar in patients with both positive and negative margins, according to Dr. Kieran's recent analysis of nephron-sparing surgery for bilateral Wilms tumor. Therefore, local recurrence in favorable histology Wilms tumor did not seem to be affected by margin status in settings where radiation therapy was given as appropriate. This finding was also confirmed by Dr. Davidoff and colleagues from their institution at St. Jude, looking at overall survival and renal function in a large single institution cohort of bilateral Wilms tumor. And the last question is somewhat related and a little bit esoteric, but what is better, more kidney with a positive margin or a negative margin with less renal parenchyma?
That is really a charged question, isn't it, Dr. Aldrich? I think that's really the million-dollar question. But the paradigm here for bilateral disease is we are trying to spare nephrons because we know that these patients are at risk for chronic renal failure and other kidney function-related morbidity in the future. So I think our study shows that we should continue to carefully explore the avenue of positive margin followed by radiation is probably okay. But again, we need to do that within the constraints of protocol and studies and be very careful about the way we analyze our findings.
I agree. I think as surgical oncologists, the ultimate goal should be negative margins whenever possible. And we know that for anaplastic histology, particularly diffuse anaplastic histology, if relapse occurs, the overall survival is extremely poor. So the first chance is really going to be your optimal chance. So achieving negative margins should be our goal. This becomes a little more challenging in the setting of bilateral Wilms tumor and particularly large advanced or aggressive histologies. And so I think this will be something that will be very important to study in upcoming trials. We also know that hypertension following radiation therapy to the renal remnant is not uncommon. And so the expensive positive margin may be accepting an increased rate of hypertension, which if the patient survives is an easy trade to make. So I think those are some questions and concerns moving forward in the next bilateral Wilms tumor study, and particularly important for these aggressive histologies such as anaplastic. So Dr. Romeo, thank you very much for answering our questions and exploring some of these deeper issues, and we hope you enjoyed the presentation.
Thank you.
Thank you for the opportunity to present our research, which looked not just at the expression of programmed death ligand 1 in drug-resistant neuroblastoma, but also included an exploratory study of checkpoint molecule expression more broadly, which I'll also present today. I have no disclosures. Neuroblastoma is the most common extracranial solid tumor in early childhood and accounts for 15% of all cancer mortality. When it's high risk, prognosis is poor, with 5-year mortality under 40%. Therefore, novel effective therapies for advanced diseases are needed. Fortunately, innovative cancer treatments are being explored. Immunomodulatory checkpoint molecule inhibitors have been successful new treatments for chemo-resistant and metastatic cancer in adults, from melanoma to non-small cell lung cancer to Hodgkin's lymphoma and others. To give a broader overview, immunomodulatory checkpoint molecules typically prevent the immune system from inappropriately reacting with healthy cells. They're often T-cell mediated and are regulated by multiple co-stimulatory and co-inhibitory interactions. Cancer can hijack these regulatory pathways to prevent immune recognition and destruction. Demonstrated here are some examples of these positive and negative regulatory pathways that may act in suppressing local immunity in the tumor microenvironment. On the left represents what molecules may be expressed in the tumor cell, and on the right, what may be on the tumor-infiltrating lymphocyte, and whether it exerts positive or negative regulation. I want to draw your attention to two of these pathways, and particularly the programmed death 1, programmed death ligand 1, and cytotoxic T lymphocyte-associated protein 4 pathways. These pathways are of particular interest since multiple FDA-approved drugs that block them are currently on the market. Many novel immunotherapies within which inhibit other pathways, including LAG3 and BTLA4, are being developed too. In terms of checkpoint molecule research in neuroblastoma, some work has already been done. Multiple studies have evaluated the expression of PD-L1 via immunohistochemical staining, but with mixed results. Some studies have shown higher PD-L1 expression may be associated with worse survival. And a few FDA-approved CTLA4 and PD-L1 inhibitors are being used in phase 1 and 2 trials for the treatment of pediatric solid tumors, but each trial only has a few neuroblastoma patients. Our lab is unique in that we have established drug-resistant cell lines which may offer new insight into these pathways. In this study, we hypothesized that PD-L1 expression and select checkpoint molecule expression could serve as a mechanism for drug resistance. Our aim was to determine if neuroblastoma cells express PD-L1, and if present, do doxorubicin-resistant cells have a greater expression of PD-L1 than wild type? We also aimed to benchmark other immune checkpoint molecules expressed by neuroblastoma cell lines and within the cell culture media. In order to execute this study, we first created doxorubicin-resistant cell lines using SKN-SH, AS, and DZ wild-type cells, and exposed them to increasing concentrations of doxorubicin over a 6-month period. Cell viability was determined using an MTT assay. We then determined the invasiveness of both the doxorubicin-resistant and wild-type cells using a matrigel invasion assay. This served as a surrogate of metastasis in vitro. Finally, we determined the expression of various checkpoint molecules. We started with Western blotting specifically for PD-L1, and then moved on to use the Human Immune Oncology Checkpoint Protein Panel. This first results slide demonstrates that we were indeed able to create a doxorubicin-resistant cell line for the SH, AS, and DZ cell lines. Next, we're able to prove that our doxorubicin-resistant cells were in fact more invasive than their parenteral wild-type cells and had an average invasion of just over 30% compared to the wild-type, which were near 10%. After creating our resistant cell lines and proving they were more invasive, we then began our exploration for checkpoint molecules. We started with PD-L1 because there are available drugs on the market which inhibit this pathway. Interestingly, PD-L1 was expressed in both wild-type and doxorubicin-resistant SH and DZ cell lines, but only in the DoxR AS cell line. After finding PD-L1 on Western blot analysis, we then proceeded with our checkpoint protein panel, identifying other checkpoint molecules and expression levels between the wild-type and doxorubicin-resistant cell lines. Although this is a busy slide, I'll try to draw your attention to the important points. Cell lines had detectable levels of 13 of 17 checkpoint molecules, whether wild-type or doxorubicin-resistant. 2 additional molecules, PD-1 and CTLA4, were found in the SH and AS wild-type cell lines only. However, there is no significant difference in level of checkpoint molecule expression between the wild-type and doxorubicin-resistant cells for any of the checkpoint molecules for any of the cell lines. Another way to visualize this is via a heat map which tracks log 2-fold changes and differences between wild-type versus doxorubicin-resistant cell lines. However, there really isn't much consistency and direction of change between the cell lines. And this makes sense because there is no significant difference between levels of checkpoint molecules between wild-type and DoxR cells across each cell line either. We also looked at the soluble level of checkpoint molecules and found that 3 of the 17 evaluated were detectable. These included CD40, LAG3, and PDL2. In theory, these potentially could be used as cancer biomarkers. So what does this all mean? To summarize, PD-L1 is expressed across all cell lines without significant change between wild type and doxorubicin-resistant cell lines, and therefore expression may not be related to drug resistance. Many checkpoint molecules are expressed by neuroblastoma in the tumor microenvironment, but do not significantly differ between cell lines, so further evaluation is required. But these molecules may still be useful as targets for directed drug therapy or as cancer biomarkers, especially the soluble forms. We also have more work to do. In regards to the PD-L1 pathway, we are experimenting with inhibition and hope to expand to an in vivo model and to obtain and stain patient samples. For the other checkpoint molecules, we hope to use this preliminary work to identify other targets for research. Finally, we hope to obtain patient serum samples to evaluate for checkpoint molecules as potential tumor biomarkers. I'd like to thank my lab for all the help with this research and thank you again for the opportunity to present it. You can find my contact information here and feel free to reach out with any questions. Thank you.
Hello, everyone, and welcome to the APSA Cancer Committee's APSASode. We are moving into a new discussion now, diving into high-risk neuroblastoma. This is a discussion for from the APSA Cancer Committee. Our abstract presenter, Dr. Nicholas Skirtich, thank you so much for the work that you did and for presenting to us today. Joining me today as moderators are Dr. Peter Mattei from Children's Hospital of Philadelphia and Dr. Elizabeth Tracy from Duke University. And my name is Lindsay Talbot. I'm from St. Jude Children's Research Hospital. Just a brief comment on neuroblastoma epidemiology before we get down into the deeper stuff. So 10 cases per million children less than 15 years of age annually, leading to greater than 650 new cases in North America annually. And we're discussing high-risk neuroblastoma specifically today because despite improvement in outcomes with chemotherapy intensification and anti-GD2 immunotherapy, less than 50% of our high-risk neuroblastoma children are going to survive and less than 10% of those who have recurrent disease. So you can see over here the COG's blueprint for research for neuroblastoma in 2013 just showed the vast difference in survival between high-risk neuroblastoma and the intermediate and low-risk groups. Here is just a quick reminder of how we determine high risk. So this is based on the International Neuroblastoma Risk Groups. So first, based on stage, so L1, L2, M, and MS, which is basically determining whether there are image-defined risk factors and whether or not there's metastatic disease. In addition to that, age, NMIC status, Pleiadi, and 11q aberrations are included in that risk group determination. And so here you can see the INRG risk grouping and what we like to refer to as the INRG tree, which can really help walk you down which risk group you're going to wind up in. And again, we'll be talking about high-risk neuroblastoma today. Standard of care for high-risk neuroblastoma is basically composed of 4 phases. There's an induction phase, which is 6 cycles of intensive chemotherapy, followed during which the patient undergoes hematopoietic stem cell harvest for subsequent use. Following this is local control, typically between cycles 4 and 6 of induction, and the goal is greater than 90% resection while avoiding major injuries or issues, which Dr. Mattei will get into shortly. Following local control, we'll have single or tandem myeloablative chemotherapy with HSCT rescue, sometimes can be tandem HSCT rescue, and radiation therapy is appropriate. And then finally, the maintenance phase, which is composed of immunotherapy with the anti-GD2 monoclonal antibody dinutuximab with GM-CSF supplementation and isoretinoin to promote differentiation. And Dr. Mattei can take over.
Great, thank you. So just a very brief reminder of what the surgical principles are when it comes to high-risk neuroblastoma. The focus in general is on the primary tumor and perhaps the local regional lymph nodes. It's somewhat unusual, not unheard of, for us to be requested to address a metastatic site. But in general, we're talking about the primary tumor. And so, for example, in the abdomen is a classic example, and then local regional lymph nodes. And as Lindsay stated, the goal is to remove as much of the tumor as possible. But we also want to minimize surgical complications. And sometimes that's a fine line, and we sometimes have to make major decisions in the operating room, of course. Some of us refer to this as the best safe resection. That's our goal. And so the resection is to remove, the goal is to remove as much as we can. 90% is a sort of rather arbitrary cutoff, although there are some studies that suggest patients in whom you've been able to remove 90% or more of the tumor tend to do better. But is that because the patients who are able to have 90% removed do better, or the fact that we remove 90%? That is still unclear. So, of course, preoperatively, any surgeon plans for an operation with due diligence and a healthy paranoia about making sure that they have a good feel for the anatomy. Typically, patients will receive neoadjuvant chemotherapy, and we love to see these very large tumors shrink down to something that's a little more manageable. We tend to use MRI at CHOP, but a lot of people still use CT scans. It really is local preference, as long as you have a good feel for where the vessels are and where the major structures are. The challenges for these tumors is that they tend to be, at least up front, they tend to be very vascular. And that's why it's nice to have neoadjuvant chemotherapy on board to make the tumors less vascular, but it doesn't make them any less adherent to adjacent structures. And that can be a tough problem in the operating room. And that's where you get into trouble sometimes with pancreatic biliary structures and major vessels. And they can also encase vessels, which makes it very difficult sometimes. And again, that's where good surgical judgment and patience pays off. And of course, we try to keep the goal in mind, and that is to remove as much as possible without causing harm. Intraoperatively, again, it's the same mantra: maximal volume reduction, preserve organs and structures. It's tempting sometimes to want to remove a kidney, for example, if that's the only thing keeping you from getting most of the tumor out. But of course, it's better for patients if you can keep the organs in place, especially the kidney. That photograph above, that cartoon is a very old slide. I remember seeing even before I was a fellow. And the tumors aren't usually as difficult as that, but the dissection is not usually as easy as that either. I always found that sort of comical. But and sometimes if you're lucky, you can get down to a gross total resection like is depicted in the photograph below. But again, best safe resection is the goal. Post-operatively, many of these patients actually, just again, mostly due to the resiliency of children, do quite well. These are big operations. We can generally avoid, for example, in the abdomen, a thoracoabdominal incision, and we are having more and more success with enhanced recovery after surgery protocols, where we can avoid drains and even nasogastric tubes and feed the children pretty quickly. And for most of our patients, the length of stay, barring a complication or an 8-hour operation, for example, where they end up in the ICU or whatever post-op, can usually go to the floor, and they're generally home within 3 or 4 days. And outcomes are based on, of course, whether or not there's recurrence and overall oncologic outcomes, but also on surgical complications, and vascular injuries are the main focus of those.
Thanks, Peter. As frustrating as neuroblastoma can be, one of the things that I think can be more frustrating to surgeons is that the tumor biology will often outfox the operations that we do. As Lindsay stated before, still children with high-risk neuroblastoma have a greater than 50% risk of relapse, and relapsed or refractory disease has much worse outcomes, with those children having less than 10% chance of long-term survival. Children who do survive, furthermore, end up with long-term complications, including chronic health conditions or disabling conditions in up to 80% of survivors. For these reasons, as a community, we've reached many of the limits of intensifying the traditional therapies that we have: surgery, radiation, and chemotherapy, and have looked for other strategies to manage children with neuroblastoma. This has led to increasing interest in other strategies that might increase survival while decreasing or minimizing morbidity, especially long-term toxicity. And that's where we get into the realm of targeted therapy or precision medicine. Often for surgeons, precision medicine is still a bit of an ambiguous term. Recently, the APSA Cancer Committee put out a paper to help define precision oncology for pediatric surgeons, and to sort of discuss its relevance in a lot of the tumors that we treat. But briefly, the National Cancer Institute defines precision medicine or precision oncology as an approach to patient care that allows physicians to select treatments that are most likely to be effective based on genetic understanding of the patient's disease. And this is really hinges on the use of novel therapeutics that are targeted towards actionable mutations. Just to define some terms for surgeons, targeted therapy is a drug with a known and a specific mechanism of action, and an actionable variant or actionable mutation or target is a gene variant determined to be likely to alter protein function and with evidence linking that variant. Additionally, biomarkers are gene variants or tests measuring the presence of a gene variant that is expected to predict the response in a targeted variant. So in many solid tumors which we treat, this strategy is especially appealing. In pediatric solid tumors in general, they're more likely to have sporadic or inherited genetic mutations than adult type tumors, and especially tumors with undifferentiated histology, relapsed or refractory tumors, tumors where rates of actionable mutations may be higher, including relapse disease, and chemo-resistant tumors. These are the tumors that may benefit most from this strategy. These are also the tumors that tend to vex us the most, both in the surgical oncology and oncology communities. Thus, the interest in targeted therapy is especially high for these type of tumors, which include neuroblastoma, especially high-risk relapsed and chemo-resistant neuroblastoma. So current targets in neuroblastoma, I'll be very brief in the interest of time, but as we know that ALK mutations occur in 10% of neuroblastomas, but up to 25% of relapsed neuroblastomas, sensitivity to the CDK4 inhibitor and ALK, other ALK inhibitors has been demonstrated. And so the rationale between next generation personalized neuroblastoma therapy trial for relapsed refractory neuroblastoma is really based on this. Biopsying the tumor in relapsed neuroblastoma for deep sequencing to identify these and other actionable mutations. Also, the RAS/MAP kinase pathway has been a recent target of interest in terms of targeted therapy for neuroblastoma. As appealing as precision oncology and targeted therapy is, there are some limitations. One is resistance to targeted therapies. Just as tumors can become chemo-resistant, tumors can become resistant to targeted therapies through a couple of different mechanisms. One's mutation within the target. An example of this is the BCR-ABL interfering with binding of imatinib. Another is reactivation of the targeted pathway, either upstream or downstream from the target, which is why it actually is important to understand the pathways involved in some of these targeted therapies. Activation of alternate pathways to bypass the targeted therapy, and crosstalk within the tumor microenvironment. Example of this is cell-to-cell and cell extracellular matrix interactions, such as those that influence resistance to the PI3 kinase mTOR inhibitors. And so I think that precision oncology, precision medicine, and targeted therapies have great promise for neuroblastoma, and should be something that we as a pediatric surgical community are both excited about, but also recognize some of the limitations for. I wanted to ask about your in vitro data regarding the potential targeting of the PD-L1 pathway is quite exciting. But what cautions or problems do you foresee in development of resistance against this target, and how does that affect your experimental design for your animal model? Thank you.
Hi, Dr. Tracy. Thank you for the question. There is concern that just as neuroblastoma develops resistance to standard therapy, it could develop resistance to PD-L1 inhibition as well, as has been shown in the adult population. Therefore, in any anticipated phase 1 or 2 trials, we would expect it to be combined with other checkpoint inhibitors or standard chemotherapy, and we'd consider doing similar combination treatment in our model.
That's a great question. All right, so just sort of tagging on to what Lisa said, so we're basically floundering around trying to find something more effective to treat these patients. And so in addition to precision medicine and precision oncology targets, another way we can do this is to employ completely different pathways. So immunotherapy is attractive because immunotherapies rely on pathways that conventional chemotherapies typically do not employ. So those pathways to which neuroblastoma cells can be resistant, we're going to sort of bypass those by activating the immune system. So the options that we have are to use monoclonal antibodies. In the case of neuroblastoma, monoclonal antibody therapy is FDA approved and is in fact standard of care. We can also use checkpoint inhibitors, the subject of our talk today, which are in clinical trials for neuroblastoma, and then adoptive cell therapies for neuroblastoma, which are in preclinical and early phase clinical trials, and I'm not going to get into today. So dinutuximab is really a success story for treatment of pediatric malignancies and improving outcomes using an immunotherapy. So it's a monoclonal antibody against a disialoganglioside GD2. It's expressed on most neuroblastoma tumors, and it's not expressed on normal adrenal tissue and sympathetic ganglia. You can see representative stain slides over on the right-hand side of the screen. The effector mechanism of any monoclonal antibody, but of dinutuximab, is to basically enhance antibody-dependent cellular toxicity. So enhance the activation of NK cells, neutrophils, and macrophages, help them to do their jobs better, and help enhance and initiate complement-mediated killing. So the early phase clinical experience was encouraging, since it's now moved into standard of care. But so early investigators found that GD2 was near uniformly expressed on neuroblastoma cells. And early phase trials, they did find that you needed to limit or target minimal residual disease settings, which is why it has ended up in the maintenance phase of therapy at this point. As one of my mentors likes to say, well, any cancer does better any therapy does better for cancer in a minimal residual disease setting. But in fact, for neuroblastoma, we've shown that in early phase clinical trials. The other thing that we learned about dinutuximab therapy was that we can enhance activity by administering GM-CSF and potentially IL-2 as well. So GM-CSF likely rescues antibody-dependent cellular toxicity in post-chemotherapy patients, so basically potentiating the effect of the antibody. IL-2 was included in the initial COG studies and in fact is co-administered in a lot of immunotherapy studies in order to really provide additional stimulus to the lymphocytes, T cells, in order to enhance their activity, but has since been removed from protocols due to toxicity and questionable efficacy. So this is just going quickly through the COG data. ANBL-0032 provided randomized phase 3 data that supported dinutuximab use with GM-CSF, isoretinoin, and IL-2 in the maintenance phase of high-risk neuroblastoma therapy. And you can see up here in the right-hand side the survival curves from this study, and it's really quite remarkable. So for overall survival, seeing a change at 2 years from 75 to 86%, and to see that change continued out over time, up to 6 years since randomization, see similar really quite impressive jumps in event-free survival and overall survival, including in high-risk patients greater than 1 year old who have stage 4 disease. So this is really, a success story here. And I'll just say that ANBL-0931 subsequently provided follow-up safety and toxicity data, and these are basically patients who had received this treatment but weren't necessarily randomized in the initial trial, so their data was included subsequently. Just to sort of, some folks who are familiar with this may be familiar with dinutuximab beta, which is was initially trialed in Europe. This is an anti-GD2 monoclonal antibody. It's a similar antibody. It's humanized, just the cell of origin of the production of the antibody is different. And this was a multi-institutional trial, 406 patients randomized and 277 ultimately completing therapy. And the important thing to know about this trial is that the EFS and overall survival was very comparable to what we saw in the American trials, but they did not see improved outcomes when they had added IL-2 to dinutuximab beta alone. And in fact, a lot of the patients who received IL-2 had to either drop that therapy or drop out because of limiting toxicities, which provided some of the rationale for removing it from our current standard of treatment. So just quickly, how dinutuximab therapy is sort of evolving. Currently, we have ANBL-1221, which is evaluating the addition of irinotecan and temozolomide in the post-consolidation setting, along with dinutuximab, GM-CSF, and isoretinoin. And then we have investigators looking at, transitioning the anti-GD2 antibody therapy into the induction setting and whether or not that can lead to a survival advantage by moving that therapy early on, given the success we've seen in later stages. So to return to the topic of our presenter's talk, and just to discuss checkpoint inhibitor therapy. So this is basically a way of removing natural breaks that the immune system has in order to help the patient's own immune systems more adequately clear pathogens or malignant cells. So upon interaction, so basically your tumor cells will express these inhibitor proteins, PD-L1 and CTLA-4, for example. And then when the T cells recognize those antigens, they basically go into a shutdown mode. They basically say, okay, we've been told to stop by an appropriate ligand. We're going to turn off cytotoxicity pathways. So by blocking that interaction, you can prevent the off switch from being thrown, resulting in sustained T cell activity against tumor cells. And there are multiple checkpoint inhibitors currently available in the United States and FDA approved for multiple different malignancies, more so in adult tumors than in children. So for neuroblastoma, thus far, there's been limited efficacy. So this is not a formal meta-analysis, but just in my review of 43 reported evaluable patients with NBL included in clinical trials, 39.5% of those patients treated with checkpoint inhibitor therapy had stable disease, and then 60% of them had progressive disease on therapy. And there have been no reports of partial or complete responses. So right now, neuroblastoma is not responding to checkpoint inhibitor therapy. And that may be due to limited PD-L1 expression in neuroblastoma patients. So if you look in the evaluable early clinical trials, you see a PD-L1 positivity rate of 0 to 14%. So if the patient doesn't have the ligand, then the T cells aren't receiving the off switch anyway. So blocking that interaction is not really necessarily going to make a difference. And the other thing is limited immunogenicity of neuroblastoma cells. So in some of these studies looking at the histology, infiltrative immune cell populations are present, but they're not demonstrating cytotoxic activity in evaluated neuroblastoma samples. So I want to move into a summary. So high-risk neuroblastoma outcomes remain poor, multimodal therapy is critical, and the evolution of targeted therapies, precision medicine, and new approaches to immunotherapy are really the frontiers in high-risk neuroblastoma treatment. We're at the point where we're not necessarily going to do more surgically, and we're already about as intense as we can possibly be in terms of conventional anti-neoplastic chemotherapy. So the work presented today, I think, is really addressing quite a significant challenge in that, enhancing checkpoint inhibitor therapy in neuroblastoma really is a frontier in terms of trying to get better outcomes for these patients. And so I really want to thank our presenter, Dr. Skirtich, for doing the work along with his group and for presenting it to us today, and to thank everyone for listening, and my co-moderators, Dr. Matei and Dr. Tracy, for joining me. And I do have a question for Dr. Skirtich. And it follows on what I just said. So given that the early phase clinical data and histopathologic data indicates that PD-L1 is not highly expressed in neuroblastoma, how do you anticipate augmenting potential PD-L1 inhibition efficacy? So are there adjunctive treatments or strategies to induce PD-L1 reactivity, or do you plan to target a subset of patients for whom PD-L1 is expressed? And so I look forward to hearing those answers.
Dr. Talbot, thank you for your questions as well. And if you don't mind, I'll answer them in reverse order. In short, yes, we plan to target the subset of patients for whom PD-L1 is expressed or use it as a salvage therapy. In terms of clinical and histopathological data, there was initially conflicting evidence as to the expression of PD-L1, with some studies showing little expression. However, I think there is convincing evidence that PD-L1 is expressed in advanced stages of disease. And although we didn't present it here, we also now have evidence that demonstrate this as well using neuroblastoma tissue samples of various stages. However, it is hard to argue for the efficacy of PD-L1 inhibition if the disease does not express that substrate. Therefore, I think, like with ALK inhibitors, it may be best to reserve PD-L1 treatment to those with PD-L1 expression, or at least to those with high mutational burdens, as these have been shown in the adult population to be most predictive of a positive result. We're also exploring whether PD-L1 and other checkpoint proteins are shed into patient serum. And if they are, serum testing could be used as a screen to determine which patients may benefit most. In regard to your first questions, in order to augment the efficacy of these inhibitors, adjunctive treatment is likely needed. In adults, combination of checkpoint inhibitor treatments are often used. For example, in melanoma, they use PD-L1 inhibition in addition to CTLA-4 inhibition, and they demonstrated superior results. And in fact, this was recently done in a neuroblastoma mouse model, combining PD-L1 inhibitors and CTLA-4 inhibition, which led to greater tumor killing and immune response. So yeah, I do suspect for PD-L1 inhibition to work, a combination therapy will be needed as well to induce reactivity and augment efficacy. Hopefully I was able to answer all of your questions, and I thank you for your time.
And thank you everyone again for attending.
So there we have it. I'd like to thank all of the presenters of the abstracts. I'd like to thank the APSA-COG committee members that did the deeper dives for each of those abstracts. And I'd like to thank all of you for your participation and attention this evening. Peter, anything else?
Thank you, and we look forward to seeing people in person in the coming year.
Indeed.
Well, hello, everybody, and we hope as members of the Cancer Committee that you enjoyed our session tonight. We have looked, and at this point in time, we don't seem to have any questions in the chat. So we just want to thank the presenters tonight, both the people who submitted the abstract and those who went and did the deeper dive and developed the questions. We thought it was an excellent program tonight, and we know how hard everyone has worked on it. David?
And we'd like to thank all of you that attended the session live, and hopefully those of you that'll watch it in the future. And I look forward to hopefully getting together at some point in person and doing this in a different way. So thank you all very much and have a nice evening.